Hello, everyone. Welcome to our webinar today. My name is Marina Waters. I'm the president at Luna. Luna provides language and communication support in the form of interpreting and translating relative to today's topic. We are present in the largest regional health networks, all the way down to the small community health centers across the state, across the region. What that means is that as a company, we and our partners and clients intersect with diverse, multicultural, multilingual, and multi-ethnic individuals and their communities. That, of course, includes immigrants, refugees, the deaf, hard of hearing, and others who do not use English as their primary language or who need help communicating with those people. What we know from working with these communities is that disparities exist and persist in multiple indicators of their health and diseases, social determinants of health, such as transportation, employment, etc., and other aspects of their life in general create additional challenges to accessibility. We know that the ACA excludes undocumented immigrants, and so that there are over 7 million nationwide without health coverage and have limited access to primary care, not to mention the systemic discrimination that particularly impacts patients of color and the undocumented. And all of this puts these individuals at higher risk. That was before COVID. Since COVID, we know that accessibility to care is even harder. There's confusion about the virus, how to test, where to go, how to receive treatment. There might be fear about providing personal information to government representatives through tracking and tracing programs. And lately, we are hearing more and more from clients that patients are not returning back for routine care. So as to not let these individuals and their communities be left behind, we wanted to reach out to some of our local partners who are addressing these issues through their research, their clinical care, and to ask them for insight about how to begin to address these important accessibility issues. I'm happy to welcome our panelists today. I'm going to let them introduce themselves. Please know that if you have any questions, you can put them in the QA function on Zoom, and we will receive them. And we hope to get to them towards the end of the hour. This presentation will be recorded on Facebook Live and YouTube if you want to share it with others. So without further ado, panelists, can you please tell us your name, your role at the organizations you represent, who your organization are serving, who are your stakeholders, and why you think this topic is so relevant at this point in the pandemic. Dr. Dixon, we'll start with you.
Marina, and you can call me Brian, that's totally fine. So I'm the Director of Public Health Informatics at the Regenstrief Institute. So Regenstrief is a nonprofit organization that serves primarily the Indiana University as a partner in doing research on health-related outcomes. But we also partner with a number of other organizations, specifically for COVID, the State Department of Health, the Marion County Public Health Department, and a number of other community-based organizations to examine the impact of COVID on populations and outcomes related to COVID. So I'll talk about that in a few minutes. Do you want me to go ahead and present now, or?
We can, let's let the other panelists present and we'll come back to you, Brian. Thank you.
Yeah.
Dr. Leathers, my friend and a clinician out in our community, why don't you go ahead?
Thank you, Marina. My name's Carrie Leathers, and I'm an internal medicine and pediatrics physician at Eskenazi Health. I work at the PCAR clinic, where we care for a very diverse patient population. We care for a large Spanish-speaking population, many immigrants and their families. And I also am assistant professor at the Indiana University School of Medicine, so I have a hand there in educating medical students and residents as well in the primary care setting.
Thank you, Dr. Leathers. Stacy?
Hi, thank you, Marina. My name is Stacy Walters. I am the Chief Quality and Compliance Officer here at Shalom Healthcare Center. We're located on the west side in the international marketplace, so we see a fairly large immigrant and refugee population. Our patients, we've served 14,000 in 2019, ranging from about 50% African American, 25% Latinx, 20% white, and then that 5% making up the immigrant refugee population. We're in a medically underserved area and a health professional shortage area.
Thank you, Stacy. Okay, well, what we wanted to start with is sort of identifying the challenges, setting the landscape. And Brian, Regan Street is a community leader on gathering and analyzing public health data. You mentioned that, looking at social determinants of health. Can you share with us what research is being done and what you know about the communities facing the greatest risk from COVID-19?
Absolutely. So let me do this. Actually, another screen for a moment, and then when I put this in the presentation mode, there we go. So yeah, let's talk a little bit about the data and what we're seeing in our communities. So again, during this pandemic, the Regan Street Institute has been really working closely with county as well as state health officials to track the disease and which populations it is impacting. And where those populations are so that local health departments can respond to community needs. So we really see that as part of our mission to impact healthcare and improve health outcomes for all populations. And that's been especially important in this pandemic. One of the things that Regan Street does on a regular basis is capture data from the healthcare system in Indiana. And so part of our job has been to take the data that we are privileged to have access to and send that information to the state health department so that they can populate their website with information on COVID-19 infection and impact for the state of Indiana. So many people are likely aware of the state's dashboard with the information that's on it. Part of that information comes from the Regan Street Institute and our partners. And some of the information, of course, comes from the state health department and the testing that they have been doing around the state. In addition to sharing information with public health departments, we have also created our own website for sharing information about the impact of COVID on populations in Indiana. So on the Regan Street website, you will find a dashboard that has information on testing similar to the state health department site. But in addition, we have details on admissions to the hospital, utilization of emergency departments, admission into a critical care or intensive care unit. And unfortunately, the reality that some people pass away from this disease. And so we measure inpatient mortality and present that information on our dashboard. And we capture data from all counties in the state. And so you can look at the information either as a state in total or in specific areas of the state by clicking on the map of Indiana that's to the left of on your screen. So we have been using the data from this dashboard to help our public health partners understand what's happening with various populations. So for example, beyond just measuring the number of people who have the disease or the number of people who are hospitalized, we also can look at the impact based on age groups, for example. So in this image, you can see that during the month of June and into July, the new infections were occurring increasingly among young adults. So the darker red bar is the period of the first 2 weeks of July. And you can see that it went up in children and teenagers as well as young adults. And it remained either relatively stable or declined in older populations. So we've been tracking the disease to show that initially the virus hit many older people early, and then it began to spread more acutely among younger adults and children and teens. And now we are seeing kind of in more recent data we've been looking at, it's kind of returning back now somewhat to the older crowd. So in this slide, we looked at the proportion of new infections among different age groups in June, July, August, and September. And you can see that trend of increasing infections among younger people, teens and adults, carried through August. And then in this month of September, the green bar at the top represents individuals who are either 70 years of age or older. And the proportion of people at the older end of the age spectrum began to grow a little bit in September, particularly as we got towards the end of September. And that has caused, for example, an increase in hospitalizations recently, because older adults are more likely to be hospitalized from COVID than younger individuals. Not to say that younger individuals aren't ever hospitalized. Many of them have been, but not as many proportionally as older adults. And so this is the kind of data that we've been looking and sharing with our partners so they can help communities respond to these trends. Similarly, we've been looking at data by age and race. By race as well. And you can see that what I've done here is broken up the data in between the different stages of the state's reopening. And in the first stage, the top lines are for infections and the bottom lines are for hospitalizations. So the impact, particularly on the Black community, has been significantly higher than on the white community towards the beginning of the pandemic. In stages 1 and 2, for example, there were more than twice the number of infections among Black residents of the state versus white residents of the state. That evened out somewhat, actually, and started the flip-flop in this most recent time period of September through now. But you can see with respect to hospitalization, the Black community continues to be at higher odds of being hospitalized for the disease than the white population. And so this is something that, again, our public health partners are very interested in tracking and helping their local communities to respond to. And these are the kinds of data we've been providing to them. If we look specifically at Marion County, we see actually a slightly different picture. Infections early on were slightly more so in the Black community than the white community, but over time, actually it's been more balanced somewhat, and the white population of Marion County has been impacted to a greater degree. Part of this may be driven by the fact that many hospital systems moved patients from other counties into Marion County during the pandemic. So that's an underlying kind of caveat with some of these data. And also, we continue to see a challenge with some data around race and ethnicity being missing from information that's captured in the healthcare system, and that can sometimes limit our ability to do the calculations. But certainly we've seen at the state level, as I showed before, a greater burden on minority populations than non-minority populations. So some challenges and things to note. I mentioned that race and ethnicity are often missing when someone goes in, for example, just to get a lab test. Sometimes that information is not necessarily collected and shared with the state health department. And so this can limit our ability to do some of our work, but we try to do our best to work around around those challenges. And then also precision can be challenged by statewide demographics. So for example, a lot of our denominators that we use are based on older census data. And so this census this year, it will be pretty important to allow us to measure maybe the real impact on minority communities once those data have been released. I will say that from working with our leaders, particularly in the county health departments, but also at the state health department, they're very committed to using data to drive interventions in communities. And so these data play a pivotal role in decisions that are made with community partners. And with that, here's my contact information, and we'll look forward to discussing as we move forward. Over.
Thank you. Thank you, Brian. We'll share that contact information with our registrants after the panel. There are people who are joining us from out of state. So one of the questions that did pop up was, what state are we, is your data referring to? And I will say it's from Indiana. Indianapolis, Marion County is our most populated county in Indianapolis. Are we at 2 million here, more or less?
We're at 2 million in the metro area. There's just under 1 million people who live in Marion County.
Yes. Okay. So I just wanted to give that context to people who are in other cities across the nation. So what I immediately saw was what you got to is what's missing from that data, right? And that is why it's so crucial that we have Dr. Leathers and Stacy from Shalom here to speak to some of that population that often goes missing in the data. Dr. Leathers, as a physician on the ground at PACAR, which is a federally, you can tell me what the designation is of PACAR, but it's Eskenazi is our downtown health network. And can you tell us what your biggest concern is about the impact of COVID on your patient communities? What do you think is missing from that data?
I can't give you Marion County or Indiana specific numbers, but we know on a nationwide scale that our Latinx population, and this is lumping them all together, okay, which it's really a diverse group of people, but lumping them all together, we know that in over 20 states, they're twice as likely to be ill with COVID-19. I believe 3 times as likely in about 11 states. And I know in parts of California, they've accounted for nearly 3/4 of infections in some areas. And this is really what I'm seeing in clinic also, unfortunately. Of all of my patients, without a doubt, my Spanish-speaking patients and their families have had a lot of personal experience with COVID-19, whether that's through illness themselves, family members who've gotten sick, and then a lot of other impacts that are, I think Brian spoke to this a little bit, the healthcare, and you as well, actually, the healthcare disparities that are already present, the health inequities in this country have been really brought out during the pandemic. And so when we look at marginalized groups like our Spanish-speaking immigrants, the 8 million approximately undocumented immigrants have really been particularly negatively impacted during the pandemic. There's a few, I don't know, do you want me to go on a little bit more about some of the areas I've seen patients most impacted, or come back to that in a little bit?
We can come back to that, Carrie. I won't forget. Let's give Stacy a chance to speak about, Stacy, I know that Shalom Health Centers do service the Hispanic and Latinx populations, but you also mentioned there's numerous other ethnic and lingual groups that you serve. Some of the languages of lesser diffusion or rare language groups and smaller cultural communities. And I'm just curious, what has been the biggest challenge for your patient population this year? And what about your providers, the staff at Shalom?
Definitely. In terms of our patients, so we're looking at a large proportion of Hispanic and then that other category. And I always say, don't let the other category go unnoticed. It's making up languages of Nepali, Somali, Arabic, Ethiopian. So sometimes those are our biggest impacts and our biggest stories. Definitely when we're talking about health inequities, health disparities, social determinants of health, all those buzzwords, it's just actually getting the information to them in their language. We're seeing even there was Spanish is often the most translated language, and our Spanish speaking population was first having trouble understanding, knowing how to navigate the healthcare system in terms of where do I get testing? How do I get testing? What does this mean for me and my family? Let alone those subpopulations that aren't accessing it in their own language. So I would definitely say, without a doubt, language and like health literacy, when that goes into that, are we translating it in a way that's even understandable? In terms of providers and our staff, it goes into more operations. I'm very admin here at Shalom, so I'm glad we have Dr. Leathers on the call. But in terms of our providers, it is being abreast of those clinical updates that were happening nearly every day through April through June. So being abreast of those changes, communicating and implementing it in our clinic, and then ensuring safety for our staff and patients. And then in terms of the staff, grabbing onto those changes, knowing how to navigate them daily. We had structural changes. There had to be an isolation area in the clinic that was designated. So what does that look like, and what team members are staffing that? And then capacity with our own staff of how are we covering if we're tested and we're out. At the beginning, it was still the quarantine for 7 to 14 days. So numerous people doing different job roles. And then making sure we are wearing appropriate PPE, whether that's goggles, masks, gloves, sanitizing for our patient safety, and communicating why this is happening to our patients and communicating it to their language to ensure confidence in Shalom and healthcare providers and their safety.
Thank you, Stacy. I'll interject here just for a moment, especially for those that are on the call outside of Indiana. Indiana does have is one of the fastest growing immigrant populations in the nation. We know that close to 15% of our population here in Marion County do not speak English in the home as their first language. We have a larger percentage here of deaf and hard of hearing because of our deaf schools. So as a company, we are providing monthly close to 100 different languages to our local clinics. And so this surprises many people, but a clinic like Shalom on any given month, or institution like Eskenazi might have anywhere from 25 to 50, the bigger hospital systems up to 90 different languages represented even in a month. So with that, why don't we pivot back to Dr. Dixon, to Brian. I know that one of the concerns with patients either just not accessing care, their COVID care, but their care in general. You and I spoke prior to this panel about, from a public health perspective, some of the long-term risks that come with patients when they stop seeing their physicians, and when healthcare systems sort of aren't available to certain individuals. So could you speak to that? And then I will follow up with that back to you, Carrie, so you can speak a little bit more with specifics about your patients and what's missing for them. Go ahead.
Yeah, thanks. So first I want to kind of add on to what Carrie and Stacy said. One of the challenges we've seen, particularly outside of the urban areas, is the ability for individuals who speak another language to access information on where to get care. And for example, if you show up in one of our counties outside of the metro area to a clinic for care that's not part of the Eskenazi system, for example, then you have to fill out the registration form on your mobile device in your vehicle, and it tends to be all in English. And so that can be challenging for individuals who don't have smartphones. It can be challenging for people just because of the fact that it's all in English. So I know some people get help from their kids or whatever if they're in school and can speak English and help their parents navigate the form, but it's a real challenge because that translation service is not always available in rural areas or less urban areas, I should say. So that is a concern. I think we have noticed a real challenge with people essentially delaying care during this pandemic. So this was very acutely evident back at the beginning, right, in March and April, when the state and many other states were on lockdowns and people were encouraged to stay home. People were not coming in for some of their regular care, or if they started to have chest pain, for example, they may not call 911 or come in because they didn't want to get coronavirus. They were fearful of getting coronavirus. They weren't sure. They thought maybe the hospitals were full of COVID patients and they didn't want to, either bother people. So there's a number of reasons why people stayed away from the healthcare system. But that has had some severe consequences for individuals. We've already started to see individuals who delayed their care during that time, then end up presenting to the hospital later with more severe complications from their diabetes or their congestive heart failure or another illness that they may have had previously and would normally get care through their primary care doctor, but they delayed that care and then they end up in the hospital later and may have more severe consequences. This week, for example, the Centers for Disease Control and Prevention released an early estimate of what they call excess mortality, which is a really weird term that most people don't know what that means. But what it means is that it's the number of people who have died that we would not otherwise expect to die based on past historical data. And the numbers this year for 2020 are very high. And this doesn't mean that all those people died of COVID, but what it means is that someone who potentially delayed care back at the beginning part of this year may have ended up dying this summer or more recently from complications from that other disease, and whereas they would have not otherwise passed away. We wouldn't have expected them to get to the point where they would succumb to their disease and pass away this year. And so the implications for this pandemic go far beyond just the individuals directly infected with COVID. And that is really concerning because minority populations in particular are fearful of either contracting coronavirus if they enter the healthcare system, or showing up at some of these sites for testing, because the messaging, I think, has largely been around, oh, it really affects these populations, and and they may feel like they're being targeted, for example, and that also helps to keep them, for example, from making decisions to come in for care. And so I think it's really important. Public health organizations have wanted to work with those populations to help them understand that these issues and address some of these fears, but that can be very challenging during the midst of the pandemic itself. And I'm sure Dr. Leathers and Stacy can talk more from their individual experiences, but that's what we're seeing, statewide and nationally. Over.
Thank you, Brian. If we have time at some point, we'll come back and talk about sort of the impact on the larger community too, because you and I spoke about that in the past, economic and the impacts, like you said, they ripple far out. But I do want to get a chance to pivot to Dr. Leathers and ask her, is this what you're seeing on the ground? From your perspective, are your patients able to receive accurate information about COVID? Are they able to navigate the complexity around not only COVID, but just accessing other care in general? And just anything else you'd like to share, Dr. Leathers?
I've actually, I was very impressed. I've continued to be impressed for patients who are Spanish speaking. They've really done well to access information. It's often a somewhat younger population comparatively than maybe my patients overall, and they do well accessing information. And I think, as Stacy pointed out, Spanish is, CDC, Luna, and many places had information in Spanish out very quickly, Eskenazi as well. And we have many Spanish-speaking providers, many Spanish-speaking staff members, nurses, medical assistants. And so I think getting information about about the pandemic was fairly accessible for my Spanish-speaking patients, comparative just for general information. When it comes to testing, that continues to be confusing for everyone. I think that for me, when I look at my patients and listen to them, kind of bear witness to what they're experiencing, I think the issues have been more around fear of accessing care. As you mentioned, I think, Marina, when you're looking at patients who are already sometimes fearful of accessing care, they've spent the past few years in particular facing increased discrimination and some policy at a national level that's been discouraging. And so accessing healthcare, like you mentioned, putting your information out there where you feel like you might be tracked or targeted. The changes around the public charge rule have caused a chilling effect. This was prior to the pandemic, but it's worse now. So this chilling effect refers to when there are policy changes, like around the public charge rule. For those of you who are not familiar with the public charge rule, I'm not an expert. But the public charge rule looks at what services an immigrant accesses and whether they would be considered sort of a burden. This is old rule, but recently has been redone by the government to include more things. So, for example, we've seen in the past couple of years less families accessing supplemental nutrition. Also, people commonly call that food stamps. We've seen people de-enrolling their children from Medicaid, even though they're citizens. So kind of looking at all of this, we call this a chilling effect when there's a policy change that affects people beyond those who are actually directly impacted by the change. So, 8 million children living in homes in the United States where there are undocumented immigrants can be impacted by this. And then it's worse during a pandemic when you have to choose between maybe life-saving care and fear of repercussions for being an immigrant. Additionally, a big fear of my patients on a much simpler level, maybe not simpler, but on a more personal level, has been separation from their family. And I think everyone has felt this, not just in the immigrant community, but people were afraid to go get tested. They thought if they were positive at a testing site, they would be sort of held captive and taken into the hospital and isolated and not allowed to return home. And then there's a lot of downstream impacts of that. Well, if I'm positive and I have to quarantine, I live with 10 people. What do I do? Or I'm positive, I have to quarantine, but I'm the only person who works in my home, and I also support family members in another country on top of that. There's just a lot of layers to what it means to get tested and be positive, even if you're not deathly ill.
Thank you, Dr. Leathers. Before we speak about strategies and trust and how to establish trust with these communities, which is an important thing to get to, I wanted to take a little deeper dive into telemedicine. It's becoming a new standard. It's evolved our provision of care. As language providers, we've evolved with that. And those of you that are on the ground we have heard are having mixed results. It's working great for some people and for others it's not. So Stacy, you and I spoke about that prior to the panel. Can you speak of how telemedicine has played out with at Shalom, at your health center, and maybe in particular with some of the members of the communities that we've been speaking about?
Yes. So in April, May, Medicaid lifted their rule on telemedicine and kind of pushed that through for reimbursement and access purposes, which was great. We've all been hoping for that for many years, but it was also that it's go time. So it was kind of a short time frame in which providers needed to be trained, front desk needed to be trained, and you saw front desk training the patients and how to access this. So I think a lot goes in between implementing we're offering telemedicine, but there's a lot of steps before that, right? So definitely a learning curve for the providers. And then if you think about the patients accessing it, like Dr. Dixon said, most of these are in their portal, their patient portals, or their online access, or anytime you are accessing this information via equipment, it's usually in English. Consent is in English. Navigation is important. So we had to call patients and make sure they knew how to do it, or hook them up with language services to make sure they knew how to do it. And then we were seeing fairly decent uptake in the white and Black population, but we did notice a lower uptake in Hispanic and other ethnicities, that for primary care and behavioral health, which is also important in the time of social isolation and high stress. So not to mention, if we're in a community healthcare center, we also see a high homeless population that doesn't even have equipment. So are they going to facilities that would usually provide that link with the equipment and Wi-Fi? Those links are closed because of COVID or lockdown. So kind of dual, like, yes, good, but also still mighty barriers, especially in the ESL communities.
I think it's really important for providers and hospital administrators to realize some of the challenges. So thank you for elaborating on that. I can speak to the deaf and hard of hearing community. Virtual care is not always ideal for communication purposes. And I think it's important to mention things like not only access to devices, but good Wi-Fi that provides a clear signal. Because when you're communicating using sign language, things like video quality really matters. So Carrie, oh, go ahead.
I just add a little anecdote to that too. We do have a Spanish-speaking patient that is also uses ASL, but in Spanish. And so we saw where a clear mask even helps, so they can see facial expression and nonverbal better, because this isn't really relating to telemedicine, but we saw that barrier where communication couldn't be emphasized with a general mask. So I thought that was important for that community to know that too.
I have one of those to show the audience at some point. Quickly, Carrie, what about telemedicine for you? And then what I'd like to do is turn to some of these strategies. So we have some time for that. How's telemedicine played out with your patients? I will say, because she won't brag about herself probably, but Dr. Leathers is a bilingual physician. And so she does have the unique ability to communicate directly in Spanish with your patients, but not necessarily other languages.
You know, I'm going to share something positive, because Stacy's right. Telehealth really got pushed to the forefront of healthcare very quickly, and this was positive. This is a positive change, but it's going to take us months and years to figure out how to exactly best implement. But early on in the pandemic, when everything shut down and we were all at home, even a provider, I was at home. Initially, the clinics were closed to try to figure out how to, I guess, mitigate risk and reopen safely. It actually was very heartwarming to connect with patients, and I actually used the Doximity app. So really, it was mostly phone calls or video chats. It didn't require managing the electronic medical record or any of those apps, which I think was helpful. Because there weren't language barriers per se. You just had to open a link in a text message or answer your phone. But I know Eskenazi is really committed to improving telehealth, and I felt that I felt like our patients felt safer to see that we were still connected. And I had the unique opportunity to do weekly phone visits, actually video visits, with a patient who had spent about a month intubated at Eskenazi and then returned home. And someone just a few years older than myself, I must add. So to watch her, what the condition she was in when she first came home, and then to get to see her progress and improve over several weeks was really heartwarming. Also really tragic, but very heartwarming. And so I think there are many positives to telehealth, though many kinks to still work out.
Thank you. I think those real life stories really help bring home some of these challenges that we're talking about. So thank you, Carrie. Let's start talking about more positive, because I would hate to leave with just this sense of doom, and there are a lot of us and people on this call that are working actively to regain trust and to roll out some new programs and strategies. So Brian, can you speak to what you and your colleagues are working on to get information out to people who may not be seeking treatment right now? What solutions is Regan Street coming up with. I know there are grants being written. I know that there are immunization programs that are already in place that must certainly be getting ready to roll out once we have a vaccination. So yeah, we are excited to hear what we can look forward to from your institution.
Yeah, well, we're doing a number of things we work most closely with the county health departments. And then the county health departments often play this pivotal role in their community of acting as a bridge between the medical community and community-based organizations. And so what we are encouraging our public health partners to do is with their community-based organizations. So the food pantries and the Red Cross and the churches and the groups on the ground working with all various populations, older adults, the Black community, the Latinx population or Hispanic populations, working with with those groups to get them information about what's happening, like the importance of testing. What happens if you get tested, if you test positive. A lot of health departments I work with community groups to identify places where people can go to quarantine if it's not possible to quarantine at home, helping people understand what quarantine means. Similarly with vaccination, working with community groups to help them understand, the reality is, vaccination is probably not going to happen this year. A lot of people keep promising it will, but there's a number of challenges to getting a vaccine. First, we haven't even determined that one vaccine is safe enough to be distributed to people. So it'll likely be sometime next year. And so setting up coalitions in the communities so that when a vaccine becomes available, it can, one, get out to providers where people can go in to actually receive the vaccine, but also preparing that information and communication with their constituents to understand what does vaccination mean and who in that family unit should get vaccinated first, right? Who are the priority populations that should be vaccinated against the disease? As obviously when it first comes available, there will be a lot of people who want to get the vaccine, but we want to make sure it's distributed in a way that individuals who are most at risk or most vulnerable to COVID-19 will receive the vaccination first, and then we'll inoculate or vaccinate others against the disease as the weeks and months move forward.
I know that there's also programs envisioned to help distribute rapid testing to those communities.
Yes. Yeah, so we want to see rapid testing. That we expect that rapid testing will be available in many primary care offices, probably over the winter. So people will be able to get tested at their local health clinic rather than having to go to a specialized site for testing. And also that there will be greater use of other testing strategies such as saliva-based testing rather than the swab up your nose, which is uncomfortable for many people. So moving those testing technologies out to communities. The other thing that a lot of our county health departments are interested in being able to do is to test people at community events. So when, over time, as community events kind of resume in the community, we want to be able to bring testing out to people so that if they're going to a blood drive or they're going to a county health fair, for example, that they can receive testing at those events rather than having to come to a dedicated testing site.
Thank you, Brian. Stacy, we know Shalom Health Center as a system of clinics that have established trust with their patients. And I think a lot of even big health systems could learn by some of the techniques and strategies that your health center have used prior to COVID, right, to establish that sort of trust and confidence, and just really build that relationship. Can you speak to some of the strategies that you are already using, or maybe new ones that are using? We have about 8 minutes left, so if you could speak for a few minutes on that, and then I have like 1 or 2 questions if we can fit in there, we'll do it.
Perfect. Yes, I think that Dr. Leathers and I are in a unique situation where we both work at federally qualified health centers that serve anyone regardless of ability to pay. We can put them on a sliding fee and offer them discounted prices, so they don't have to show any extra documentation if they don't have it. So that's one. And secondly, I would say probably first, we need to recognize and acknowledge medical mistrust and historical trauma in the patients and the that we serve. So I know as a clinic, we have done lots of training on what does privilege and biasness in healthcare look like, or what does intersectionality look like between cultures and how we offer care. What does being culturally responsible and culturally responsive, and offering humility when we offer care. We also try to hire a diverse staff reflective of our patient population. We know representation matters. So I'm proud to work at a health center where that is one of our forefronts when recruiting. Additionally, that whole person care with these high need patients, we have to realize it's more than their health care, physical health care, it's their mental, emotional, spiritual. So I definitely think that being able to connect them in-house in that one-stop shop to the social worker who can help with financial strain, the behavioral health team that can help with substance use or mental health and social issues, or the pharmacist that offers nutritional education, all for that one person, and having a hands-on, all people on deck approach has really helped us. And then other side things are obviously language services and a language line. Transportation, so Uber Health is a thing, so picking up patients to and from. And yeah, I was happy to have my staff train on these services that we offer, and then the all the different bias and privilege training, so different assessments, self-reflections to hopefully gauge some what's my status, where am I at, where was I, and where am I going. We did some pre and post surveys as to what does my care look like now, and am I learning enough to offer more quality healthcare with that in mind.
Perfect. Thank you, Stacy. We probably won't have time to get this today, but I will send in our follow-up a link to some research that has been done at Regent Street around bias through the healthcare provider. So I think as we're all speaking about bias and discrimination, it's important to see how it plays out in that patient and healthcare provision relationship. And there's some new research on that we'll share. A question came up, which I hope we can spend just a minute, either Carrie or Stacy, you can answer this. Maybe we'll let Carrie do it, but are you giving any visual okay, so the question is around, I think it came up with the telehealth program and accessing telemedicine and language services to those who don't speak English. The question is, are there any visual representations that you provide to your patients. And I think that underneath that question is how do you educate your patients on how to use these services, right? They're all amazing tools, but there's a challenge there because, as it's been mentioned several times, most of the tools are only in English. So how are you getting around that, Carrie, in terms of just educating your patients on how to use the tools you need them to use to communicate with you?
Yeah, so that's a great question. We have, some of our, from a Spanish language standpoint, a lot of information we provide to patients about using the online portal is already we have that available in Spanish, and they can use those resources in a Spanish language version. We also wear badges within our clinic that say Español, or providers who have been certified as at least advanced in their abilities to speak Spanish. So this lets our patients know coming through the door that there are many people like me who they may not look at me initially and know that I'm going to speak Spanish. So to see that badge in their language is really helpful, and hopefully does give some visual clues to the inclusivity of the environment. I wish I spoke other languages. For other languages, it's more challenging, and there are places like Luna that help us get other things in other languages.
What about you, Stacy? How have you approached that challenge of just educating the patient? Let's speak to those who don't speak Spanish, for example.
Yes, I like the example Dr. Leathers gave. We do have, in terms of who we serve, we might have a health human rights sticker, or a LGBTQ flag, or pronouns, to let people know that we are inclusive and able to help them in their area within whatever culture they're identifying with. Then we are lucky to have an in-house, I think most medical providers do, the electronic education that can be printed off in multiple languages, but that really gives any type of language is available with care plans, decision aids, food logs. I think that is a type of visual aids that patients can really find useful.
Great. Thank you, Stacy. I was just asking my colleague to go grab a sign. She may not be able to find one right offhand, but we have these signs that basically literally just say ASL here in signing it out in the hands. I can't do it. Our interpreter can do it. ASL here. I also wanted to show someone referenced masks with windows, which allow especially the deaf and hard of hearing to read lips in a way that they were prohibited from doing with masks. So these are some of the tools that people wouldn't have to wear all the time, but could slip on, when they were communicating with those populations. We are out of time. Unfortunately, we could all probably speak about these topics for quite a while. If any of you have any closing things to say, I want to give you each an opportunity to do that, just like a minute or two each, and then we'll close off. And as I said, give contact information through follow-up links in case anyone wanted to reach you. And we'll be sending also some articles out that our panelists and links that our panelists thought would be useful. Brian, any last remarks?
Just that, we are at Regan Street are committed to kind of fixing some of the underlying data issues and making sure that data is captured and shared in a very transparent way so that communities have the information they need to serve their constituents and help support the health of the people who live in that community.
Thank you for saying that, Brian. I know it's greatly appreciated. And Dr. Leathers, any last comments before we go?
Thanks for giving me an opportunity to speak today. I think any chance we have to advocate for the health of our state and our community and our country is invaluable.
Thank you. Stacy, any last remarks?
I'll just say I agree to both. In clinics, we're data driven, and any advocacy is so important for this community. So any chance that we get to help or aid is our pleasure. And if you want any kind of resources or our contacts, we're more than happy to give that to you.
Thank you so much. We appreciate all your participation. Luna, as some of you have mentioned, remains a resource to our community, to our clients, and just anyone who gets in that situation where they have someone in front of them that they cannot communicate with. We want to continue to help be part of the solution to this issue of accessibility. So we look forward to continuing this conversation. And I so appreciate your time and all the work you're each doing in the community to serve these populations. So thank you so much, and continue to do the good work that you do. Thank you.